Tendoscopy-assisted FDL tendon transfer and spring ligament synthetic suture tape reconstruction for flexible PCFD technique performed in conjunction with minimally invasive medializing calcaneal osteotomy and Hoke Achilles tendon lengthening. Procedures indicated for patients with symptomatic flexible PCFD with hindfoot valgus, medial longitudinal arch collapse, and forefoot abduction at TNG up to 40 degrees. Lateral radiograms confirm apex plantar break of the Mary's line. Dorsoplantar radiograms confirm moderate forefoot abduction. Commence with minimally invasive medializing calcaneal osteotomy with patient in lazy lateral position. Operated leg up under fluoroscopy guidance. The safe zone for neural structures is marked by drawing a line joining posterior, superior, and plantar prominences of the calcaneal tuberosity and a parallel line 11 mm anterior to it. Mark the osteotomy starting point at the midpoint of the posterior line. Soft tissues are elevated dorsally and plantarly off the lateral calcaneal wall using a periosteal elevator. Using 3x20 Shannon burr aiming for anterior safe zone line and dorsal calcaneal line crossing point, proceed with the dorsal cut. Plantar cut is parallel to the posterior safe zone line. Hemostat is advanced through the osteotomy side and anterior under the lateral wall to produce a shift of 10 to 12 mm. K-wires are placed, plantar wires aimed towards the center of the anterior calcaneal process and dorsal wires short of the posterior facet subchondral bone. Screw length is measured, drill holes established, subchondral countersinking is performed. A shift is secured with short thread 7 mm diameter headless compression screws. Follow with tendoscopy-assisted FDL tendon transfer and spring ligament synthetic suture tape reconstruction. Position supine. Foot is in externally rotated position. The distal portal is marked 0.5 cm below the navicular tuberosity. The proximal portal is marked at the sustentaculum tali. Establish proximal portal. Perforate the investing fascia with the hemostat and direct it towards the fifth metatarsal base. Open and withdraw. Arthroscope is introduced in the same trajectory. Distal incision is performed. Hemostat is advanced to the view, then open and withdrawn. Shaver is introduced via the distal portal onto the arthroscope shaft, slid down to the tip of the arthroscope. Shaving is commenced to clean out the soft tissue obstructing the view. Often fibrous tendon sheath needs dissecting to encounter FDL. Once FDL tendon is visualized, sheath dissection is carried out from proximal to distal until the FDL and FHL crossing point, known as the knot of Henry, is visualized. FDL tendon identity is confirmed by isolated lesser toe motion. Labral scorpion arthroscopic suture passer is employed to tack FDL tendon with the fiber wire suture proximal to the knot of Henry. One strand is passed through the loop and secured by pulling both strands. The foot is inverted, lesser toes plantar flex, deliver FDL outside the distal portal, place hemostat under it and open. Tenotomy is performed at the most distal accessible point. Place the Alice tissue forceps on the FDL, retrieving stitch is removed, and number 2 fiber loop is used to whip stitch 2.5 cm of the tendon. Retrieve the tendon through the proximal portal by placing hemostat from proximal to distal portal and pulling on the whip stitch. Under fluoroscopy guidance, 1.35 mm guide wire is placed into the sustentaculum tali, angled 15 degrees plantar to avoid subtalar joint penetration. Drill with a cannulated 2.7 mm tap with a 3.5 mm swivel lock tap. Via composite swivel lock 3.5 by 15.8 mm loaded with number 2 fiber tape is introduced. Via the distal portal guide pin with eyelet, short 2.4 mm is introduced into the navicular plantar medial to dorsal lateral. Cannulated headed reamer 0.5 mm larger than measured tendon diameter is used to drill the navicular tunnel. Retrieve FDL tendon whip stitch and number 2 fiber tape from proximal to distal portal. Feed both into the guide pin. Pass number 2 fiber tape first and then whip stitch plantar medial to dorsal lateral via pre-drilled navicular bony tunnel. Pass flexible suture passing wire into the navicular tunnel. Invert the foot, adduct the forefoot, tighten number 2 fiber tape by hand, tighten the FDL by clipping and rolling the whip stitch with the hemostat on the dorsolateral side. Remove the eyelet and the fiber wire from the swivel lock. Cut the eyelet off the suture passing wire to be able to mount a swivel lock anchor onto it. Advance by a composite swivel lock 4.75 over 19.1 mm over the wire. Final radiograms are obtained and saved on PACS. Hokey Achilles tendon triple hemisection is performed. Incisions are closed with 3/0 monocryl. In the case example at 6 weeks, weight-bearing clinical images confirm restored neutral hindfoot alignment, restored medial longitudinal arch. Mary's line confirms restored medial column. Tailor first metatarsal axis confirms restored forefoot abduction. Thank you.